Hello, my name is Quentin Broussard. I'm Assistant Professor of Clinical Sciences at California Health Sciences University, and today we will be discussing multiple sclerosis, or MS. The reason that we're discussing this topic is because MS is a chronic neurological condition characterized by decreased neurological function and potential long-term disability. There is currently no cure, however, there are treatments available to minimize relapses and to treat complications of MS. As a pharmacist, it is important to be aware of MS treatments that you may encounter in practice. Our objectives today will be to classify the types of multiple sclerosis, identify treatment options for multiple sclerosis, and assess pharmacotherapeutic agent selection considerations for MS. We'll start off with a patient case. GT is a 36-year-old female presenting to her physician for an annual checkup. She was diagnosed with multiple sclerosis 3 years ago after her second MS flare in 2 months. Following her MS flares, GT had no other MS flares following that. Besides her 2 flares, she's had no other MS symptoms. Which of the following types of multiple sclerosis does GT most likely have? Is it relapsing-remitting, secondary progressive, primary progressive, or progressive relapsing? As a follow-up question, GT's multiple sclerosis has never been considered aggressive or rapidly evolving by her physician. Which of the following agents is GT most likely to be on considering her disease course? Is it Alemtuzumab or Lemtrada, Dimethyl Fumarate or Tecfidera, Fingolimod or Gilenya, or Natalizumab, Tysabri? Which of the following agents may cause GT to have bradycardia and AV block, requiring cardiac monitoring after the first dose is administered? Is it Alemtuzumab, Lemtrada, Dimethyl Fumarate, Tecfidera, Fingolimod, Gilenya, or Natalizumab, Tysabri? After conclusion of this lecture today, I hope that we will be able to answer all these questions correctly and confidently. To start off, we will define what MS or multiple sclerosis actually is. Multiple sclerosis simply is an inflammatory disease of the central nervous system, or CNS, and it's characterized by destruction of myelin as well as axon that are found in the CNS. Now remember, your CNS includes your brain, your spinal cord, and for the purposes of MS, also your optic nerves. So destruction at any of these places can further go on to produce neurological symptoms. In terms of why MS is actually called MS, the term multiple stands for number of lesions in the CNS. And for multiple sclerosis to be defined as multiple sclerosis, there has to be at least 2 CNS lesions, either in the brain, spinal cord, or in the optic nerve area. Sclerosis is defined as demyelinated lesions or plaques, and these are areas of the brain or spinal cord that do not have their myelin protection for their axons, and as a result of not having protection, these axons may be degraded into lesions or plaques. For epidemiology of MS, MS affects 250,000 to 350,000 Americans and over 2 million people worldwide. Diagnosis occurs often between the ages of 20 to 50 years old, so these people can be young adults or middle-aged adults. Often it affects women more than men in a ratio of 2 to 1. And those who are of North American descent are at the highest risk. And this actually has to do with the level of latitude where we are compared to the equator, and I'll show you that in a map in a moment. In terms of prognosis for MS, 50% of patients will need assistance walking within 15 years of disease onset, whether that be with a cane or with a wheelchair or a walker. So MS is very debilitating depending on how your disease progresses, and it can affect your activities of daily living, such as walking or getting around. To show you what I was talking about in terms of North American descent being at the highest risk, looking at this map, North America actually falls into that red area, which is high risk, as well as some areas of Europe and Iceland and England, as well as a lower area of Australia and New Zealand. And the reason why this is that these areas are furthest away from the equator. The equator goes approximately through the northern part of South America and parts of Africa. Near these areas, the risk is the lowest. It's kind of unknown why it's like this. It just is. There might be something environmentally that causes that high risk to be further out from the equator, or 0 degrees latitude. So keep that in mind wherever you go to practice. If you go to practice in Africa or South America, for example, you might have a low incidence of MS. Compared to if you stay here in North America, you may see a higher incidence of MS compared to other countries. And the latitude where the highest incidence occurs above is around the latitude of the Oklahoma Panhandle, which is located around this borderline right here. Anything above that Oklahoma Panhandle area is considered high risk for our purposes. In terms of pathophysiology of MS, pathophysiology of MS is actually unknown. There are many different speculations and theories out there in regards to MS pathophysiology. However, we won't get into that as they are very technical. There is one theory, however, where MS is believed to be caused by a combination of a genetic factor and potentially a non-genetic factor or a non-genetic trigger. So there may be something genetic that people with MS have. However, it is triggered potentially by a non-genetic trigger. And that non-genetic trigger can be something like a virus, a metabolism issue, or an environmental factor. And one of the environmental factors that you'll see as a risk factor is smoking or cigarette smoke exposure. To give you an idea of what the progression of MS looks like, we'll actually take a look at the brain and the spinal cord. So in terms of our brain here, in terms of a coronal view of our brain, we have healthy brain here on the left side, which has intact gray and white matter as well as ventricles. However, further along in MS, you may actually develop relapsing-remitting disease. And this relapsing-remitting disease is characterized by a white matter demyelination as well as cortical demyelination. As this demyelination is occurring, the axons are no longer protected, and potential antibodies as well as autoantibodies are attacking these unprotected neurons, and that causes atrophy, demyelination, as well as ventricular enlargement with increasing atrophy. As you can see here with the spinal cord view, because remember, MS also affects the spinal cord, we have our healthy spinal cord areas on our left with the white and gray matter. But whenever someone has MS, you may have demyelinated areas or lesions that occur. And these demyelinated lesions and demyelinated areas may actually lead to a lot of the neurological symptoms that you see with MS. In terms of risk factors for MS, a family history of MS, autoimmune disease, or migraines may be a risk factor. Now, in terms of family history of MS, it may increase your risk of MS, though it's not very common. Some statistics say it might be as low as 5%. Autoimmune disease is also a potential risk factor for MS. as it's believed that antibodies are attacking these demyelinated neurons. Migraines as well as cigarette smoke exposure are also potential risk factors. As you remember, cigarette smoke exposure may be one of those environmental factors that play a trigger in triggering MS. For classification of MS, MS is classified into 4 different types of MS depending on your disease course. Relapsing-Remitting MS or RRMS, Secondary Progressive MS or SPMS, Primary Progressive MS or PPMS, and Progressive-Relapsing Multiple Sclerosis or PRMS. Now, the initials are not important to remember as we'll always specify it out with its long definition. So if we were to say RRMS, what we'll write out is Relapsing-Remitting MS, as it can be very confusing with these different abbreviations. Now to define these actual classifications. Relapsing-Remitting MS, or RRMS, is actually the most common MS classification, and it affects over 85% of MS patients. Relapsing-Remitting MS is classified by flare-ups, relapses, or exacerbations of MS, followed by periods of remission. This is actually how MS is commonly diagnosed. A patient may come into an emergency room or to a doctor with an MS flare and not know that they actually have the disease. Symptoms will improve or disappear during remissions of this disease classification. So a patient may have a flare, then once their flare is over, their symptoms improve or they may disappear. Doesn't mean that their symptoms necessarily disappear completely if their symptoms improve, though. So just keep that in mind. A patient may have secondary progressive MS, or SPMS. This SPMS, or secondary progressive MS, may develop in patients that have the relapsing-remitting MS that we just talked about. The disease course worsens with or without remission periods or a leveling off of symptom severity or symptom plateaus. So, essentially what happens is the disease will get worse potentially after each relapse. Now, it's kind of hard to tell when patients are actually in secondary progressive MS, and it's very uncommonly diagnosed. Another type of MS is primary progressive MS, or PPMS, and this type of MS affects about 10% of MS patients. In these patients, symptoms worsen from the beginning gradually. So whenever they begin to have MS, their symptoms will continue to get worse. There are no relapses or remissions. So essentially what happens is once you have the symptoms don't go away and they don't stop. However, the symptoms may plateau for a bit. This type of MS is more resistant to drug treatment than the other types. So just keep in mind that some drugs may not work very well for PPMS. The last type of MS is progressive-relapsing MS, and it affects only about 5% of MS patients. It's very rare. It is progressive from the beginning, and you actually may have intermittent relapses or flares of worsening symptoms. So, in addition to the type we just talked about, this type actually has relapsing symptoms. So, the relapses may make the symptoms a lot worse. There are no periods of remission for PPMS. In terms of clinical presentation outside of the classification system, a lot of MS patients will have many different systems of their body affected by the disease. Some of the most common types of symptoms a patient may have include moderate to severe spasticity in the legs, so they may not be able to move their legs as well. They may have sensory disturbances, and this can include dysesthesias, which are essentially pinpoint or burning sensations, diplopia, which is double vision. They may have ataxia, vertigo. They may even have bladder disturbances, which may make going to the bathroom a little bit more difficult. Patients may experience unilateral numbness affecting one leg, neuralgia as a result of the demyelination of the axons. Now remember, we also talked about optic nerves being in play with MS. Therefore, patients actually may develop optic neuritis. Other things that may develop include constipation, fatigue, which the fatigue may actually cause patients limitations in their activities of daily living, making it harder for them to do normal daily activities, such as even drive or work. These patients may have sexual dysfunction, and they may have psychiatric disturbances such as depression, difficulty with memory, and concentration. For diagnosis of MS, there's no single diagnostic test that is significant to define MS. There are some criteria, however, that are used to help the diagnosis. One of these is to find evidence of 2 different damaged areas of the CNS, and that can be in the brain or the spinal cord. These damages should have occurred at least 1 month apart from each other. It's also important to observe symptoms for more than 24 hours and episodes separated by at least 1 month. In terms of what can actually identify lesions the best for MS, magnetic resonance imaging, or MRI, is the gold standard to try to identify different lesions. And as you can see here on the right on this slide, these arrows are actually pointing at different lesions of the brain of an MS patient. So you see these little white areas here, which, as you remember, with a CT, they may mean blood. But in this case, with this MRI here, they actually represent lesions. And these lesions are essentially empty areas where demyelinated axons are. A spinal tap is necessary to examine for oligoclonal bands, which may be significant for MS. In addition to all these diagnostic criteria, it's important to exclude all other possible diagnoses before diagnosing MS, because the neurological symptoms that we saw on the previous slide actually may be similar to a lot of other disease states that you may see in the elderly or with other neurological diseases. In terms of disease progression, this illustration actually gives a very good idea of disability throughout the life of a patient. So if you actually look here at this solid red line is significant for brain volume. And as patients age, they have more demyelination occurring. As a result of that demyelination occurring, there is less and less brain volume that is available. As you see here, as time goes on, disability also goes up as a result of axonal loss from the demyelination of neurons, as well as your autoantibodies, as well in your immune system essentially attacking your neurons. And you have heightened disease progression, which may eventually lead to primary progressive disease. Now, in terms of what this clinically isolated syndrome means right here, which is not a term that we've actually used before, it's actually a term that means that a patient had a one-time episode of MS. Sometimes these episodes are treated with MS drugs. However, for the purposes of this presentation and for this topic, we won't go into clinically isolated syndromes. Just be aware that they are a thing and that they may be treated in practice. However, remember with the definition of MS, you need to have at least 2 symptom episodes to be considered a diagnosis of MS. Now to talk about the goals of therapy. For MS, the goals of therapy are to prevent permanent neurological damage, to decrease relapse incidence or flare incidence, avoiding disability if at all possible, and maximizing the quality of life. As you remember, most patients may not even be able to walk if the disease progresses far enough. So maximizing that quality of life that they have now is very important. In terms of first-line treatments for MS, there are 4 that are currently recognized. And those 4 are dimethyl fumarate or Tecfidera, Teriflunomide or Aubagio, Interferon Beta, which comes in a variety of different products, Avonex, Plegridy, Beta-Seron, Extavia, and Rebif, and Glatiramer acetate or Copaxone. The first agent we'll talk about is dimethyl fumarate or Tecfidera. Essentially what dimethyl fumarate does in terms of its mechanism is it induces expression of anti-inflammatory proteins, which may be important in trying to decrease relapses and progression of MS. An important thing to know is that dimethyl fumarate is a PO available option for patients. So patients can take this medication by mouth. You'll see with a lot of the other MS medications that a lot of the other MS medications are either intravenous or subcutaneous. Just keep in mind that this actually may limit a patient from being able to use the drug. So whenever you have a PO option, it is preferable. Dosing for dimethyl fumarate is 240 milligrams by mouth twice daily. And in terms of studies looking at dimethyl fumarate, it has a reduction in clinical relapse rate of about 50%, which is pretty significant. And in terms of the other first-line agents, this agent is actually the highest in the reduction of the clinical relapse rate, though many of these agents haven't really been compared head-to-head. Adverse effects for dimethyl fumarate involve flushing, abdominal pain, nausea, vomiting, diarrhea, lymphopenia, as well as progressive multifocal leukoencephalopathy, or PML. Now keep PML in the back of your mind because we will discuss it with a few of the other agents that we're going to talk about today. The next agent we'll talk about is teriflunomide, or Aubagio. Teriflunomide is a pyrimidine synthesis inhibitor which reduces B and T cell activation, function, and proliferation. So essentially it's kind of suppressing the immune system. Like dimethyl fumarate, this is also available PO and is dosed 7 to 14 milligrams by mouth daily. It has a reduction in clinical relapse of 30%, which is less than dimethyl fumarate's 50%. And it also has adverse effects of nausea, vomiting, diarrhea. It has transaminase elevations associated with it, as well as potential hepatic failure, some electrolyte disturbances, and acute renal failure. It has a risk of SJS or 10, alopecia, and neutropenia, and leukopenia. So these agents are essentially affecting your different blood counts. For interferon beta, there are a variety of products out there, as we mentioned. And in terms of mechanism, there are different anti-inflammatory and immune modulating mechanisms by which it's believed that these work for MS. This agent is available IM or sub-Q, and depending on which type of interferon beta you have or product, the dosing varies depending on the formulation. and it can be every other day dosing to every week dosing to every 2 weeks or even every 4 weeks, depending on which one you pick. It has a reduction in clinical relapse rate of about 30 to 35%, which is similar to Aubagio. For interferon beta, it's important to remember that with most interferon products that you may have injection site reactions. You also may have a high incidence of flu-like symptoms, and for interferon beta, these are very common, with about over half of patients having flu-like symptoms. Interferon beta may also cause depression or suicidal ideation, transaminase elevations, as well as decrease in lymphocytes, as well as leukocytes. And the last first-line agent that we'll discuss is Glatiramer acetate, or Copaxone. What Copaxone, or Glatiramer, does is it suppresses T-cell activation, induction, and activation of suppressor T-cells. It is available sub-Q, and the dosing is traditionally 20 milligrams sub-Q daily, or 40 milligrams sub-Q 3 times a week. For a reduction in clinical relapse rate, this drug has about a 30% reduction in clinical relapse, similar to many of the other agents in its class, other than Tecfidera or Dimethyl Fumarate. For adverse effects or adverse reactions, you may see injection site reactions, as this is an injection. For Glatiramer specifically, post-injection, you may see flushing, chest pain, palpitations, or dyspnea. Now, while these are very scary and may mimic ACS or a heart attack, it's important to monitor these patients, especially whenever they're getting their first few doses of this medication. Glatiramer can also cause menstrual disorders, urinary tract infections, and leukopenia. So those are our 4 first-line agents. And you see here that they have a relative reduction rate of anywhere from 30 to 50% in terms of clinical relapse. Now, if these agents don't work as well, you may go to a second-line agent depending on the patient's disease progression, as well as potential adverse effects of some of these medications. For second-line treatments of MS, we have 3 main treatments, and that is Natalizumab or Tysabri, Fingolimod or Gilenya, and Alemtuzumab, Lemtrada. The first agent we'll talk about in terms of second-line therapy is Natalizumab or Tysabri. It is a recombinant humanized monoclonal antibody, and the way that this works is that it may prevent leukocyte migration across the blood-brain barrier. One issue with theories of pathophysiology of MS is that there may be some kind of autoantibody or some kind of immunological response that is happening in the periphery that eventually may get transferred into the CNS. And it's believed that that migration into the CNS is one thing that helps to propagate MS. So by preventing leukocyte migration across the blood-brain barrier, essentially Natalizumab is preventing part of that peripheral to central migration. Natalizumab is available IV, and it's dosed every 4 weeks at 300 milligrams IV. In terms of reduction in clinical relapse rate, this agent has a reduction of around 68%, which is higher than the other first-line agents. However, with Natalizumab, you do have a variety of adverse effects, and though these actually look similar in number to the other agents that we've described so far, some of these adverse effects can be relatively serious. In terms of adverse effects, Natalizumab includes headaches, fatigue, arthralgia, and depression. It's important to note that because this is a monoclonal antibody, if a patient receives this medication, they may be more prone to infections, as well as progressive multifocal leukoencephalopathy, which may occur more likely in patients that have autoantibodies to a virus called JC virus. As a result of this, Tysabri or Natalizumab is a REMS drug and has to be prescribed by an approved prescriber for this medication. And you'll actually find that all the drugs in the second-line therapies for MS are REMS drugs. So that includes Natalizumab, Alemtuzumab, and Fingolimod. Now to talk about Fingolimod. It's believed that Fingolimod prevents lymphocyte exiting from lymph nodes. As we talked about that migration earlier that occurs potentially from the periphery to the CNS, Fingolimod is essentially preventing lymphocyte egress or lymphocyte exiting from the lymph nodes so that those lymphocytes essentially can't get to the CNS where they can act. Fingolimod is available as a PO formulation, which does make it useful for patients who prefer not to inject themselves, and the dosing is 0.5 milligrams by mouth daily. It does have a reduction in clinical relapse of around 55%, which is similar to Tecfidera in the first line class. Important adverse effects for Fingolimod include bradycardia and AV block, and this commonly may occur after the first dose of Fingolimod. Therefore, it is important that patients are monitored for at least 6 hours after the first dose of Fingolimod is administered. They need to be monitored on telemetry with EKG monitoring. Therefore, they can detect any bradycardia or other bradyarrhythmia occurring and can treat it appropriately. You may also see transaminase elevations from this medication, headache, decreased pulmonary function, hypersensitivity reactions, serious viral and fungal infections, PML or progressive multifocal leukoencephalopathy, as well as malignancies from this medication. So, if the patient has cancer, this medication may not be the best to give a cancer patient. The last agent we'll talk about in the second-line treatment therapies for MS is Alemtuzumab or Lemtrada. Alemtuzumab is a humanized monoclonal antibody directed against CD52, and this causes rapid deletion of CD52 positive B and T cells, essentially minimizing that B and T cell crossover. It is available IV, and the dosing for this agent may be convenient for some people, as for the first treatment round, you only have to get 12 milligrams IV once daily for 5 days, and then you're done for a year. 1 year later, then you'll get 12 milligrams IV once daily again, but you'll only get it for 3 days. And this actually reduces clinical relapse rate around 50 to 55%, similar to Tecfidera. Adverse effects of Alemtuzumab include infusion-related reactions, as it is an IV medication, nasopharyngitis, autoimmune disorders, infections, as this is a monoclonal antibody. It will increase your risk of infection, pneumonitis, and malignancies. So those are our second-line agents for MS. However, there are other agents in the pipeline or that are used off-label for MS. These other treatment options include corticosteroids, which we'll talk about briefly, Declizumab or Zimbrida, Dalfampridine, Ampyra, Ibudilast, and Ocrelizumab are not approved currently in the U.S., but I just want to make you aware that they do exist in case they come out in the next couple of years. Mitoxantrone and Rituxumab are also potentially used for MS. though these agents are commonly known as chemotherapeutic agents and used for oncology patients. You also want to always consider non-pharmacological therapy for any patient that is receiving a drug therapy, if possible. For corticosteroids, the believed mechanism for corticosteroids in MS is that they may prevent inflammatory cytokine activation, inhibition of T and B cell activation, and provincially preventing those immune cells from entering the CNS. Corticosteroids, as we know, are available IV or PO mostly. In terms of dosing for corticosteroids, because these agents are actually used for acute episodes, relapses, or flares of MS, the dosing is rather high compared to your standard steroid dosing. For corticosteroid dosing, you may see patients receive methylprednisolone anywhere from 500 to 1250 milligrams IV or PO daily, or their steroid equivalent, say if they were to convert the patient to prednisone. And these patients will get these pulse dose steroids for 3 to 7 days to try to reduce that inflammation response. Again, these are only used acutely for relapses and for flares. Adverse effects of corticosteroids include GI upset, insomnia, mood disturbances, as well as hyperglycemia. And if you're in the ICU, they may even cause ICU delirium, which we'll talk about later in this course. Another agent that is just been approved for MS is Natalizumab, or Zimbrida. And this is a humanized monoclonal antibody directed against the CD25 subunit of IL-2 receptors. This agent is available sub-Q, and it's dosed monthly at 150 milligrams sub-Q. One thing to know about Zimbrida specifically is that this agent should only be used after 2 other MS agents are used, per recommendations. Adverse effects of Natalizumab include allergic skin reactions, autoimmune disorders, infections, nasopharyngitis, hepatotoxicity, neuropsychiatric events, and even tuberculosis. Therefore, it's important for this agent, as well as some of the other monoclonal antibodies that we talked about, to get a TB screening prior to administration of these agents. Dalfampridine is another agent that is available for MS. What this agent does is it's a potassium channel antagonist, and its main purpose in MS is to improve walking speed. It has no effect on clinical relapse rate. The way that it improves walking speed is because it is a potassium channel antagonist. Essentially what is happening whenever you antagonize a potassium channel is that you're having more potassium within the cell, not leaving the cell. And that stimulates action potentials to occur, which facilitate neuronal transmission and neuronal activity, therefore improving the walking speed of patients. This agent is available PO, and it's dosed at 10 milligrams by mouth twice daily. Again, it does not reduce clinical relapse rate like all of the other agents that we've been talking about. Some adverse effects from Dalfampridine or Ampyra are that Dalfampridine can cause seizures. So if you have a patient with a seizure disorder, Dalfampridine is not recommended. Other adverse effects include urinary tract infections, insomnia, dizziness, back pain, and balance disorder. Mitoxantrone or Novantrone is commonly known as a chemotherapeutic agent, and one of the mechanisms of this drug, or multiple mechanisms of this drug, include that it targets proliferating immune cells, inhibits proliferation, and induces apoptosis of T and B cells, macrophages, and other antigen-presenting cells that may be involved in the immunology cascade that is MS. Mitoxantrone is available IV, and its dosing is 12 milligrams per meter squared IV every 3 months. This does have a max lifetime cap of 140 milligrams per meter squared. So just keep that in mind. And if you calculate that out, a patient can only receive about 11 full doses of this medication. Adverse effects of mitoxantrone include nausea, alopecia as related to chemotherapy agents, arrhythmias, and cardiotoxicity. So if a patient has some kind of arrhythmia or some kind of cardiac issue, mitoxantrone is not recommended. Menstrual disorders also occur, as well as leukopenia. And urine discolorations with mitoxantrone do occur. And these urine discolorations are often blue-green, and that can be attributed to the color of the agent. Another agent we commonly see in the oncology realm is Rituxumab or Rituxan. It is a chimeric murine human monoclonal antibody directed against CD20, regulating cell cycle initiation and differentiation. Commonly, this agent is seen in treatments of lymphoma, which you'll learn about next semester. This agent is available IV, and in terms of dosing, the dosing varies depending on which study you look at. Right now, Rituximab or Rituxan is off-label for MS, so just keep that in mind. Adverse effects of Rituxan include infusion-related reactions, potential infections, as this is a monoclonal antibody, and progressive multifocal leukoencephalopathy, though only one case has been reported of this, and the person actually had other predisposing risk factors for PML. So it's unknown in larger populations whether PML is actually an adverse effect. Now that we've talked about the drug therapies that are used in MS, I want to touch a little bit on non-pharmacological therapies. One thing that you can do to try to prevent the progression of MS is to exercise. With my experience with MS, with the friend that I know who has MS, she actually exercises probably more than most people, and you can not even tell that she is suffering from multiple sclerosis. It's also important to rest as well. So don't do any activities which may be too much for you. Patients may also need assistive devices like wheelchairs, canes, walkers, etc. And it's important for these patients to also work with physical, speech, and occupational therapy as needed, as a lot of these different systems are affected by MS. For a treatment approach for MS, when looking at studies, head-to-head comparisons are limited, and adherence to a treatment is very important, as adherence to treatment dictates whether or not treatment will work. If a patient has intolerable side effects from one agent, for example in the first-line class, you may switch agents, or you may even go to an agent in the second-line class, depending on how progressive that patient's MS is. In some patients, you actually may start a second-line agent as the first-line agent if the patient has rapidly evolving, severe, relapsing-remitting MS. So if a patient comes in and they're really, really bad off, they may actually start them on one of the second-line agents first. It's important to consider off-label treatments if inadequate response to second-line agents occurs. So those are a lot of the agents that we were just talking about in terms of things like Rituxan, for example. In terms of other clinical pearls for treatment approach, please see the reading assignment review article for more details, as this gives a good explanation of the different treatment approaches that you may see in multiple sclerosis. Here are the references for this presentation, and we will go over the patient case questions. So just a recap. GT is a 36-year-old female presenting to her physician for an annual checkup. She was diagnosed with multiple sclerosis 3 years ago after her second MS flare in 2 months. Following her MS flares, she had no other MS flares. Besides her 2 flares, she had no other symptoms of MS. Which type of multiple sclerosis does GT most likely have? And the answer here is relapsing-remitting. Now remember that relapsing-remitting MS is the most common type of MS. And after an MS flare, these patients may have a decrease in symptoms or no symptoms at all, compared to a lot of the other progressive types of MS, where the symptoms may not go away after a flare. GT's multiple sclerosis has never been considered aggressive or rapidly evolving by her physician. Which of the following agents is GT most likely to be on considering her disease course? The answer to this question is Tecfidera. The reason why Tecfidera is the answer compared to the other agents is that Tecfidera is one of the indicated first-line agents for MS, compared to Alemtuzumab, Fingolimod, and Natalizumab, which are classified as second-line agents. Say if GT had a more progressive course of MS, she may be on one of those other agents. Which of the following agents may cause GT to have bradycardia and AV block, requiring cardiac monitoring after the first dose is administered? The answer to this question is Fingolimod or Gilenya. Remember that this medication, because it causes bradycardia and AV block, will require the patient to be on telemetry monitoring with continuous EEG for about 6 hours after the first dose is given. It's also why Fingolimod is partly why Fingolimod is a REMS drug and requires special providers to order it or write prescriptions for it. If you have any questions, please feel free to email me, or we can address the questions related to this lecture in class. Thank you and have a great day.